I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. Today, I'm really excited to have on board with us Dr. Eric Bricker. He's world-renowned for his videos that he puts up on LinkedIn and other platforms, and they're very informative, and we're excited to talk to somebody with such a great wealth of information.
Awesome. Dr. A, thank you so much for having me, and thank you to all the viewers and listeners for tuning in.
Thank you. Dr. Bricker, can you just tell us a little bit about yourself before we dive into our questions for today?
Sure. So I'm originally from the Washington, D.C. area, and then I lucked out and got a summer job at the National Institutes of Health when I was 16 years old. So that's how all this started. It was from a family friend at church who was like, hey, you want a summer job? I'm like, sure. So that's how all this started. And I went to Northwestern for undergrad, was pre-med. This was back in the 90s when there was Bill and Hillary care, and HMOs were all over the place. And I don't have any doctors in my family. And every doctor I talked to said, whatever you do not become a doctor because the government HMOs are ruining the practice of medicine. So I said, okay, well, I better learn about that before I go to medical school. So I actually worked as a hospital finance consultant for 2 years between undergrad and medical school. And as you can imagine, it was a complete billing disaster. So I learned all about that billing disaster back in the 90s, and then went on to medical school at the University of Illinois at Chicago. And then I wasn't really fascinated by one particular organ. I kind of liked the whole person. So I became a general internist and did my internal medicine residency at Johns Hopkins because I thought I wanted to be an academic physician and a policy wonk, because Hopkins does a whole bunch of policy stuff. But it was just a little too slow for me. I mean, nothing wrong with research and policy, but I just needed something a little faster. So I actually started a business in residency with one of my consulting colleagues, and it was a healthcare navigation firm called Compass Professional Health Services. And then after I finished my residency, I moved down to Dallas where my partner was located. And so basically, healthcare navigation is basically all the outpatient care coordination that a lot of primary care docs either don't do or don't get paid for or just don't have time to do. And so basically, we did all that. So the prior authorizations, the appointment scheduling, the moving the medical records around, we would give comparative cost and quality information for folks. And I was the sales and marketing and account management guy as a doctor. So I kind of had to teach myself how to sell, which was hard to do. And sure. And we ended up growing that business to about 2,000 employer clients. We sold our service to employers, and then the companies would offer our service to their employees. So we had T-Mobile and McDonald's and Southwest Airlines, a whole bunch of folks. And we sold that business in 2018. And then I was essentially sort of independent. And so I'm like, okay, well, I can kind of start shooting people straight in terms of what I've seen in terms of how the money flows in healthcare and health insurance. And I started making these AHealthcareZ videos that are on LinkedIn and YouTube. And believe it or not, last year, those videos had 2.3 million views. I'm shocked. It's the most boring subject humanly possible. And people actually watch it. So anyway, that's much more long-winded than you wanted, Dr. A, but that's a little bit about me.
No, that was perfect. As a matter of fact, I mean, it was your videos that really drew me in. I love your whiteboard. As a matter of fact, we've been talking in my office about potentially adopting something similar to explain some of the medical things and surgical things that I treat, because it's easy. It's easy to follow, and it's amazing. And I mean, you're obviously very humble about the impact of your videos, but they are far-reaching and they're just amazing. And again, I'm just excited to have you on board. I find it awesome to hear that you started working on billing when you were younger. My dad is a retired physician, and when I was 14 years old, I was his billing manager. This was back in the 80s. And because, healthcare finance was so much simpler. And, obviously we can go down a rabbit hole talking about how we ended up where we are. And I think there's some key turning points which took us in the wrong direction. And maybe we could touch on that a little bit later. But, one of the things that I'd really like to ask you about and see if you can give us some insight into is, the Consolidated Appropriations Act. A lot of people aren't familiar with that. They're not familiar with the impact that that is starting to have on healthcare, because we talk about in direct care, whether it's direct primary care or direct surgical care, that transparency is so important to patients understanding what they're getting themselves into. I mean, we spend a lot of time talking about the risks, benefits, and alternatives of particular treatments from a medical standpoint. But
Yep.
isn't it only fair that we should also talk about the risks, benefits, and alternatives from a financial standpoint?
Right. Very good point.
But as physicians, we're not taught to do that in medical school or residency or fellowship. And we kind of have to stumble across it. And most of us kind of figure, you know what? I just hope I don't have to have that conversation. I want somebody else to have that conversation. But, my impression with the Consolidated Appropriations Act is that conversation is now starting to come to us because of the pressures being put on employers by that. So could you dive into that a little bit?
Sure. And so the CAA, the Consolidated Appropriations Act, was recently passed just within the past few years. And it's far-reaching, it's complicated, but a summary of it is that employers, when they have a health insurance plan for their employees, it's more than half. It's about 2/3 of employees are on what's called a self-funded plan, where it's actually the employer that's bearing the risk for the employee's health. So they don't really have a quote unquote health insurance company. Yeah, you get an insurance card that says Blue Cross or United or Cigna or Aetna, but they're just the claims administrator. They don't actually bear any of the risk. It's actually the employer themselves that are kind of acting as their own little mini health insurance company, and they're bearing the risk for their employees. And that actually started back in the 70s with a law, not to get into too many acronyms, called ERISA. And so ERISA says that plan for the employer actually has to be like a separate legal entity. So it, like a pension plan, is a separate legal entity. And so the health plan for the employees is actually separate from the company. And the company itself is referred to as the plan sponsor, because obviously the company or the organization, it could be a school system or university, they give the money to the health plan, and then the health plan gives that out to the doctors in the hospitals as people get sick and need care, right? Okay, so now, bear with me. You guys are being super patient. What the CAA says is that, look, that plan exists not to serve the employer. That plan exists to serve the members of the plan. In other words, the employees and their family members. And that plan and the people who run that plan have what's referred to as a fiduciary responsibility to the members of the plan. And a fiduciary responsibility is just a fancy word for saying you have the financial best interests of the members of the plan when you're making decisions. So historically, the people who were running the plan at a company were like the head of benefits, or people within the HR department, or maybe people within the finance department, like the CFO. And so they would make decisions that were not necessarily in the best financial interest of the plan members, of the patients, of the employees and their families. They would do things like hire health insurance carrier and PBM vendors like Blue Cross United, Cigna, or Aetna, or CVS Caremark, or Express Scripts as their PBM vendor. And they would enter into agreements or they would hire a benefits consultant like Aon or Willis Towers Watson or Mercer. And those agreements were not transparent about what was actually going on with the money in the claims. So the plan would sign an agreement with a major insurance carrier, and in that agreement, the insurance carrier would say, you need to keep sending us money to pay out claims, but we can't give you any data around that. It's like basically getting just the bottom line of your credit card statement that says you owe, $3,000 for the month, but then like no individual line items of what that, like the grocery store, the gas station, right? So you're just like, you get this credit card bill for $3,000 and all the employers are like, yeah, you don't have to tell us the detail behind that. We'll just pay the $3,000, right? And so the CAA is like that is a breach of fiduciary responsibility to your plan members. Like you need to know that information now. And if you have a vendor that doesn't do that for you, that's not the vendor's fault. That's actually your fault for hiring that vendor. So actually your employees could sue you. The plan members could sue the plan for basically breach of financial fiduciary responsibility for hiring such a bad vendor. or you hired a benefit consultant, and that benefit consultant is getting commissions from the insurance carrier and the PBM. And when you entered into that agreement with that consultant, you never required them to disclose those commissions. And so that consultant is not going to work within your best interest as the plan, or the employees at best interest as members of the plan, when they're getting paid commissions by the insurance company and the PBM. They're going to work for the insurance company and the PBM. They're not going to work for you. And again, the CAA opens up the plan for being sued by the members of the plan, the employees, to be like, look, you're not having our best interests in mind. And there have been a handful of lawsuits around this. Probably the biggest one is there was an employee of Johnson & Johnson who sued the Johnson & Johnson employee health plan to be like, my medication costs thousands of dollars a month. I could go onto GoodRx and get it for like $100 a month. How in the world did you sign up for a prescription plan that costs me so much money? That's a breach of your fiduciary duty. So I'm going to sue you. So anyway, well, everything in healthcare requires long-winded answers. So there's another long-winded answer for you.
Sure. So I was going to ask you about the Johnson & Johnson lawsuit, but you beat me to the punch. So I guess, obviously, I find this very fascinating. I think some of our listeners and viewers will find it very fascinating, but I think there are a lot of them that are sitting there probably thinking to themselves, okay, well, that all sounds very interesting, but what's the impact on me as a doctor?
Right.
What's the downstream effect of this? And, just to kind of point us in a particular direction, I know for me personally, as a direct care surgeon, I have had a whole slew of self-insured employers reach out to us recently after the impact of the Consolidated Appropriations Act, saying, hey, listen, I know you offer transparency and you offer affordability. I want to include you in my plan so that I don't get into trouble with my employees and face a lawsuit. So can you elaborate on that a little bit more, some of the downstream effects of this and how it impacts Joe Schmo doctor out on the front lines?
That's right. So great point. So as a response to the CAA and the potential threat of lawsuits from the plan members to the plan, then everything in healthcare is slow. So I'd still say it's the minority of employers and the minority of self-funded plans. But they are starting to say, okay, well, we basically need to clean up our own. We need to clean up our own shop. And so part of the effort of cleaning up their own shop is realizing that the vendors that they hired, like their insurance carrier and the network that they then rely on from Blue Cross United, Cigna, Aetna, that those allowed amounts, so those contracted rates, frankly, are terrible, right? They're anywhere from 2 to 5 times what the Medicare reimbursement is, right? So like if an echocardiogram from Medicare is $300, then these folks are paying $1,500 for an echocardiogram. And for a joint replacement, if, Medicare is paying $15,000, these guys are paying $75,000. And so they're realizing that is essentially a breach of their fiduciary responsibility. And that if they enter into direct contracting directly with either physician groups or sometimes with hospital systems, then they can get much better rates that are maybe only 2 times the rate of Medicare instead of 5 times the rate of Medicare, or maybe 1.5 times the rate of Medicare. And because so many doctors have so many Medicare patients, they're like, shoot, if you're going to give me 50% more than Medicare, like I'll totally take that. It might be less than 200 or 300% Medicare, but if I can see, twice as many patients, if I can get a higher volume of patients than at 1.5 times Medicare, then I would want to do that. Now, this only works for physicians that have the capacity and the interest for seeing those types of patients. Like if the doctor's like, well, I'm maxed out, I can't do any more procedures, I don't have any more room in my schedule, yada, 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 then that doesn't work because you're maxed out. But
sure.
What the direct contracting, this is kind of the last point I want to make, is what that looks like for a primary care physician versus a proceduralist is pretty different, okay? Because as a proceduralist, you have sort of an episode of care. Let's just say the classic one is for like a knee replacement or a hip replacement for an orthopedist, where you don't necessarily have this big longitudinal relationship with that person. You have the preoperative care, you have the operation, you've got the postoperative care, and then you're kind of done. And so there, the direct contract is really for that episode of care where you're saying, hey, look, all in for that, for the anesthesiologist, for the surgeon, for the facility, for the pre-op visit, for the post-op visits, kind of all in. Let's do that for like 20 grand. And that's a lot less than 75 grand, but it's a lot more than the 15 grand that Medicare was giving me. And Walmart's been doing that for like 20 years. They've been contracting with a hospital system in Missouri called Mercy, and they send people to Mercy in Springfield, Missouri. And they've been doing, like I said, for like over 2 decades, they've been doing that. And so, but more and more employers are starting to do that. So that's kind of on the proceduralist side. Now, on the primary care side, it takes more of the form of a subscription service for a primary care physician, what's referred to as direct primary care or DPC, where there's not really an episode of care because you have this longitudinal relationship with that person. It's really a monthly subscription where typically the plan is paying about $75 per person per month for like unlimited visits with that primary care physician and their office. So the structure of that direct relationship is a little different depending upon what kind of specialty you're in.
Right. Well, and for me, from my perspective, it's really exciting. One of the things that I think I can imagine some of the other physicians out there are listening and hearing, okay, well, that's great that the employer is saving all this money, but that means I end up getting paid less. And I think, there's another layer of complexity that a lot of physicians, a lot of people in general don't understand. And it's that, when you have that insurance carrier that's acting as the plan administrator, that's a huge part of the overhead. And by cutting out that middleman and going with the direct contract, you cut out all that overhead. The employer pays less money to the plan. The plan pays more money to the doctor. And really the only people that lose out in that scenario are the insurance carriers that are administering these plans, because they've just been effectively cut out. It's a win-win for the patients. It's a win-win for the doctors and for anybody else that's providing that care. And, I can say, from my perspective as a direct care surgeon, the amount of time that we spend haggling and fighting with insurance companies, doing prior authorizations and doing all these appeals and so forth and so on, just to find out that I'm not going to get paid at all.
Right.
I mean, that ends up costing a lot of money, and we end up saving that money because with the direct contracts, it's a much quicker conversation.
Right.
And we say, okay, does this make sense? Yes, it makes sense. Okay, good. We'll schedule it, and patient will come and get it done, and the employer is like, okay, that sounds good to me.
Yep. Yeah, it's one of these things that's existed for a while. So there's also like the Surgery Center of Oklahoma that's been doing this for decades. But to your point, the CAA is part of a number of sort of forces that I think are really starting to accelerate it.
Yes. And I think the Johnson & Johnson lawsuit is a great example of that. I mean, there's a lot of pressure. And I've had a number of employers approach me saying, listen, I see what's happening to Johnson & Johnson. I don't want that to happen to me. Can you help me?
For sure.
Yeah. Well, I, for one, am very excited to have had you on our podcast today, Dr. Bricker. I'm a big fan of yours, and I'm excited to share your wisdom with the rest of our viewers and listeners. I would recommend to everybody that's watching or listening, check out Dr. Bricker on YouTube. Check him out on LinkedIn. There's a huge wealth of information there, and I've learned a lot. Much of my practice has been impacted by the things we've learned from your videos, and you're a big name in our world, and I just appreciate having you on board.
Well, thank you so much for having me. And I will say, if you want, I think that especially for doctors that are in training, whether it be in medical students or residents or like recently out, that closely tied to everything that we're talking about, I think it's super important for everyone to understand how the current RVU system works and what an RVU is. And so if we have time on the podcast, I could go into that, or if you don't want me to, that's fine too.
I think we've only got a few minutes left.
Let me say one quick thing about it. Okay. So when you get out into practice, just know that how much you do is measured in RVUs, and you absolutely need to chase down and find out how many RVUs you generate on a monthly basis. And then you have to compare that to how much you're getting paid. And so just know that if you don't know that, to Dr. A's point about people in the middle siphoning off money from you, you will not know how much money they are siphoning off from you. And so by looking at your RVUs and looking at how much you're getting paid, that allows you to find the difference in terms of how much is being taken away from you, and you will be shocked when you look at that. So if there's one sort of like hidden thing that nobody ever talks about in medical school or residency, it is the RVU, and it's something that you've got to understand.
Yes, and that's really valuable information, and thank you for that. And for those of you that are watching or listening, and you want to know, well, how do I find this out? It's publicly available information. You just need to know to ask the question. All right. Well, any last thoughts or words of wisdom for us, Dr. Bricker?
I will just briefly say that, listen, that medical school and residency and fellowship, they do not teach you everything. But what they do teach you is that you have to be an autodidact for the rest of your career. You basically have to take the initiative to educate yourself. No one's going to spoon feed it to you. And doing things like listening to Dr. A's podcast is part of that. So just know that we're all grown-ups here. That's part of your responsibility now, right? No one's going to hold your hand. You got to figure this out on your own. But the good news is that you can't, especially with Dr. A's help. That's it.
Yeah. Thank you so much, Dr. Bricker. It's been a pleasure having you on the podcast. I would actually love to have you come on board for another episode at some point in the future to talk more about the RVU system and some of the ways in which it developed and some of the pitfalls involved in that.
Sure. Yeah, absolutely. Anytime.
All right. Thank you, Dr. Bricker. Appreciate your time.
Bye.
Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.